Hello, everyone. We are from Group 19, and we would like to present our case scenario, reveal our diagnosis, and move on to more interesting details that make this case particularly unique and interesting. So this is our case scenario, and we would like to demonstrate it using a short video.
Mrs. Silva, can you please tell me exactly what happened? When did all this begin?
It started about 2 weeks ago, doctor. I had diarrhea for 2 days. It wasn't too bad, so I didn't go to the hospital. After that, I was fine for a while.
All right. And when did you start feeling
A
weak?
few days after the diarrhea stopped, I began to feel this strange tingling.
And did it spread to your hands too?
Yes. After 2 or 3 days, my arms also started feeling heavy. I couldn't hold things firmly. Even brushing my hair became difficult.
I see. What about your breathing?
That's why I came here, doctor. Since this morning, it feels harder to breathe.
All right. Any chest pain?
No fever, no chest pain, just weakness spreading upward and this numb feeling everywhere.
We'll do a few tests, but don't worry. We'll take good care of you.
Thank you, doctor.
Now let's move on to an analysis of the symptoms. In this patient, we see diarrhea, which settled in 2 days. This indicates a gastrointestinal infection that may have been caused by viruses like cytomegalovirus, Epstein-Barr virus, or bacteria like Campylobacter jejuni and Mycoplasma pneumonia. These infections can activate the immune system, which mistakenly attacks the body's own tissues, such as peripheral nerves, leading to symptoms such as we see in this patient. The tingling sensation in legs and feet is also caused by the overly active immune system, which mistakenly attacks the myelin sheath, which is the protective covering of peripheral nerves, causing inflammation and damage to the nerve fibers. Furthermore, we see difficulty breathing and progressive weakness of the body. This is also caused by the overly active immune system, which attacks respiratory muscles like the diaphragm, leading to weakness and difficulty breathing. So, why were radiological investigations negative in this patient? Since only the peripheral nerves are affected, the damage cannot be detected by a CT scan, MRI, or other radiological investigations because there is no damage to the central nervous system. However, in later stages of the disease, it may be detected by these radiological investigations. Now let's move on to differential diagnosis of this disease. We see that there are several possibilities due to common symptoms seen in several diseases. Firstly, there is a chance for transverse myelitis, which is a possibility because it also shows autonomic dysfunction and can present with lower limb weakness and sensory symptoms. However, there is a pattern of ascending weakness in this patient, which is not characteristic of transverse myelitis, and the radiological investigations were also normal. Unlike in transverse myelitis, where we can see abnormalities on imaging. Therefore, transverse myelitis can be excluded. Secondly, there is myasthenia gravis, which also causes muscle weakness due to antibodies against acetylcholine receptors. It usually presents with fluctuating weakness, particularly in ocular, ptosis, diplopia, and bulbar muscles, difficulty swallowing, speaking. But in contrast, this patient has a case of progressive symmetrical ascending limb weakness starting from the lower limbs with no ocular or bulbar symptoms, making myasthenia gravis unlikely. Next is botulism, which is caused by a neurotoxin, leading to descending flaccid paralysis, cranial nerve involvement, and sometimes autonomic symptoms. This patient has ascending weakness and no cranial nerve or autonomic involvement, which is the opposite of typical botulism progression, therefore making botulism also unlikely. Finally, we have chronic inflammatory demyelinating polyneuropathy, CIDP, where we see a slower progression of symptoms which takes at least 8 weeks, and this case involves onset of symptoms over days following an infection. Unlike what we see in this patient, CIDP does not typically present with rapid onset symptoms or rapid respiratory compromise as seen in this patient. Therefore, our final diagnosis is Guillain-Barré syndrome, GBS. It is an acute, immune-mediated polyneuropathy, which affects the peripheral nervous system. It is typically triggered by an infection and acute inflammatory demyelinating polyneuropathy. AIDP is the most common subtype of Guillain-Barré syndrome. This is a neurological emergency because respiratory muscle paralysis and autoimmune dysfunction can be fatal. So, why did we conclude this as being Guillain-Barré syndrome? Because we see a history of preceding diarrhea, which is a classic trigger for Guillain-Barré syndrome, often caused by Campylobacter jejuni infection, but can also be caused by other viral or bacterial infections. The immune response to this infection cross-reacts with peripheral nerve components. There's also progressive ascending weakness, which is typical or characteristic of Guillain-Barré syndrome. It starts in lower limbs and ascends to upper limbs and respiratory muscles. There is also the tingling sensation in hands and feet, which is an early sign of peripheral nerve involvement. Sensory symptoms often precede weakness. The normal radiological findings support peripheral nervous system pathology. In GBS, MRI/CT is usually normal. There is also difficulty in breathing, which indicates involvement of respiratory muscles due to neuromuscular weakness. And finally, no metabolic disorder, unlike diabetes or electrolyte imbalance, which are ruled out because of the rapid onset of symptoms. Let's begin with the global overview of the Guillain-Barré syndrome. At any given time, the global prevalence is estimated at 6 to 20 cases per million people. The incidence rate is roughly 1 to 2 new cases per 100,000 individuals per year worldwide. When it comes to age, the risk increases as people get older, and the incidence actually doubles in individuals over 50 years. In terms of gender, males are affected more commonly than females. Finally, looking at the regional variation, rates are fairly similar across the world. However, the incidence tends to be slightly higher in areas where infections such as the Campylobacter jejuni or Zika viruses are more frequent. In conclusion, the final diagnosis for this case is Guillain-Barré syndrome, GBS. It's an autoimmune condition typically triggered by an infection, causing the immune system to attack components of the peripheral nerves. Clinically, GBS presents as a progressive ascending weakness that starts in the lower limbs and moves upwards. Patients often experience tingling sensations or sensory symptoms before the weakness begins. When the diagnosis was established, several differentials were ruled out. Transverse myelitis was ruled out because imaging was normal. Myasthenia gravis was ruled out due to the absence of fluctuating weakness. Botulism was excluded because there was no flaccid paralysis or cranial nerve involvement. Chronic inflammatory demyelinating polyneuropathy, CIDP, was excluded because the weakness was not a slow progression over 8 weeks. Prompt recognition of GBS is vital because early immunotherapy and ventilator support can significantly reduce morbidity and prevent life-threatening complications. To summarize the key takeaway, always suspect Guillain-Barré syndrome, GBS, in patients presenting with a rapidly progressive, symmetrical weakness. Early diagnosis and intervention can make a major difference, improving both prognosis and recovery outcomes.